Welcome and thank you for joining us today for our symposium, Emerging Topics in Women's Health, Cardiovascular Health Through Every Life Stage, as part of Virginia Commonwealth University's Health of Women 2026 Summit. I'm Sarah Chu, Programs Manager at the Society for Women's Health Research. SWHR is a national nonprofit dedicated to advancing women's health through science, policy, education, while promoting research on sex differences to optimize women's health. For more than 35 years, SWHR has led interdisciplinary groups of researchers, healthcare providers, patient advocates, and policy leaders to address diseases and conditions that disproportionately, differently, or exclusively affect women, including cardiovascular disease. I would like to thank VCU for the support of this Emerging Topics in Women's Health Symposium. I would also like to thank the sponsor of today's event, the Heart Disease Research Foundation. SWHR maintains independence and editorial control over our program development, content, and work products. We'll be live tweeting during this event and invite you to join us using the hashtag SWHRTalksHeart on social media. Next slide. Today's symposium will discuss heart health across women's lifespans, with special emphasis on maternal health, midlife, and aging. Our distinguished panelists will present strategies as to how researchers, clinicians, patients, and policymakers can collaborate to address persistent research gaps, disparities, and unmet needs in women's cardiovascular health. Cardiovascular health broadly refers to the health of the heart and blood vessels. Cardiovascular disease, or CVD, broadly describes conditions of these systems, including coronary artery disease, stroke, heart failure, and hypertension. CVD is the leading cause of death in both men and women in the United States, with 1 in 5 women dying from cardiovascular disease each year. More than 60 million women in the United States are living with some form of heart disease. Women face challenges in treating heart disease, receiving less effective care, and having worse health outcomes than men due to gaps in research, diagnosis, and treatment. Additionally, women with heart disease often face misdiagnosis or have delayed diagnosis, leading to worse health outcomes, higher death rates, and more frequent hospital stays. Unfortunately, many women do not have a good understanding of their own personal risk for cardiovascular disease. While certain risk factors cannot be controlled, some can be managed or changed to promote heart health. Research estimates that over half of diagnosed heart diseases are due to modifiable risk factors. Next slide. In addition to the sex differences between men and women in heart health, cardiovascular health varies significantly across different populations of women and across women's lifespans. There are important considerations for women's heart health across the lifespan, with certain sex-specific risk factors associated with female life stages. These include age at menarche, adverse pregnancy outcomes like preeclampsia and gestational diabetes, age at menopause, and the postmenopause estrogen decline. However, women's unique life stages can provide critical opportunities for prevention, intervention, and care. Next slide. Despite the burden of heart disease on women, there are steps that can be taken by providers, patients, and policymakers to improve women's heart health outcomes across the lifespan. To that end, allow me to introduce our distinguished speakers to shed more light on these topics. Dr. Connie Graves, next slide. Dr. Connie Graves is a board-certified experienced maternal fetal medicine specialist for the Maternal Fetal Medicine Specialists of Tennessee, the medical director for perinatal services at St. Thomas Health Systems, and the state maternal medical director for TIPQC. Recognized as an international expert in maternal disease states, Dr. Graves recently became a fellow of the American College of Cardiology, in addition to her certifications in obstetrics, clinical care, critical care, maternal fetal medicine. She serves on the NIH Review Committee for the Safety in Perinatal Research. She currently holds grants for the American Heart Association, the Moore Foundation, and the NIH. She currently serves on the Finance Committee of the Foundation of the Society of Maternal Fetal Medicine. In 2014, Dr. Graves, along with Dr. Stacy Davis, a cardiologist, started the Collaborative Perinatal Cardiac Center, which is one of the first in the nation to address maternal heart care from the preconception period through postpartum care with a focus on long-term prevention. She recently completed work for the National Academies of Sciences to develop protocols to improve cardiovascular care in pregnancy and the postpartum period. Today, Dr. Graves will discuss cardiovascular health in the reproductive years, focusing specifically on research and clinical care gaps in cardiovascular health and maternal health, novel strategies and research advancements in perinatal heart health, and sociocultural factors and disparities in heart disease during pregnancy and postpartum. Next slide. Dr. Emily Lau is a women's cardiovascular health specialist and investigator at Mass General Brigham. Dr. Lau is the co-director of the Mass General Brigham Women's Heart Health Program. Dr. Lau's laboratory focuses on understanding how biological sex differences and female-specific cardiovascular risk factors contribute to the pathogenesis of cardiovascular disease uniquely in women. She leads a clinical translation research program that applies multidimensional molecular modeling, imaging, exercise physiology, and data science to large-scale cohorts, electronic health record data, and patient-oriented studies to advance mechanistic understanding of women's cardiovascular health and disease. Dr. Lau's research is supported by the NIH, NHLBI, American Heart Association, the Massachusetts Life Center, and the Yen Chow and Chrissy Chen Institute. Dr. Lau will present today on cardiovascular health in midlife with a focus on menopause and cardiovascular disease, highlighting the importance of this life stage on CVD risk. Dr. Lau will discuss risk assessment, prevention strategies, and care models for midlife women. Next slide. Claire D'Andrea has over 50 years of nursing experience encompassing integrative and holistic medicine, intensive care, research, maternal child health, and home health. She received certifications as an integrative nurse coach from the International Nurse Coach Association, certified healing touch practitioner from the Healing Beyond Borders, and clinical research coordinator for the Association of Clinical Research Professionals. Before joining the team at Guarani Integrative Health, Inc. As a provider, she worked at the Pacific Pearl La Jolla as a nurse coach and healing touch provider. Claire worked full-time as a Scripps Center for Integrative Medicine in La Jolla, California for almost 15 years. Claire also volunteers her time to support women living with heart disease for Women Heart, a nonprofit with the mission to improve health and the quality of life of women living with or at risk for heart disease and advocate for their benefit. She has been a spokesperson for Women Heart since 2004. She has presented on at many events for them and for the California Society of Cardiac Rehab. She was a member of the Women Heart Board of Directors from 2012 through 2017 and served as a vice chair of the board. She trained at the Women Heart Science and Leadership Symposium in 2004 and has been a Women Heart champion since then, holding monthly support groups and attending public health speaking events. Her own personal heart journey during the last 28 years fuels her passion to facilitate policy changes, provide education, and support women living with and at risk for heart disease. Claire will present today about her personal journey living with cardiovascular disease and how it propelled her to become her own health advocate and support others on this journey. Finally, we have Madeline Adams. Madeline Adams is the Public Policy and Advocacy Manager at the Society for Women's Health Research. Driven by a passion for advancing women's health, Madeline advances SWHR's mission by engaging in legislative and regulatory analysis, developing advocacy strategies, and educating policymakers and stakeholders on on SWHR's policies, priorities, and initiatives. Before joining SWHR, Madeline analyzed mental health policy and emerging trends at Vibrant Emotional Health, a national mental health nonprofit organization. She also served on the government affairs team at the New York City Fire Department. A former New York City Urban Fellow, Madeline is also a recipient of the 2025 Women in Government Relations Judy Schneider Fellowship. Madeline holds a Master's of Public Administration with a concentration in health policy from American University and a BA in Political Science with a minor in Human Rights from Hunter College. Today, Madeline will discuss the current policy landscape and legislative and advocacy opportunities in women's cardiovascular health and will also provide practical ways to advance women's heart health policy. After our 4 presentations, attendees will have the opportunity to engage in live Q&A with the panel. So we invite you to use the Q&A function to submit questions throughout the event. Now, let's welcome Dr. Connie Graves to join us with a discussion about cardiovascular health in the reproductive years. Thank you for joining us today, Dr. Graves.
Thank you very much. This morning, we're going to be talking about cardiovascular disease and maternal health. It is very important as we go forward. We're going to talk about the research, the clinical gaps concerning maternal health and cardiovascular health, look at some of the novel strategies that we have in perinatal populations, and of course, address the socio-cultural and disparities that exist in heart health in the pregnancy and postpartum period. Well, what is the problem? The problem is our maternal mortality rate, which is higher than any other industrialized country in the world. For non-Hispanic Black women in 2003, the maternal mortality rate was 50 per 100,000, about almost 3 times higher than that for non-Hispanic white women, Hispanic and Asian populations. Also, our maternal heart rate, our maternal mortality rate by age is significant for women over 40, 62 per 100,000. Again, almost, if you look at women in the age groups of 25 to 39, almost 4 times higher than that of the general population. We see here that maternal mortality in 2000 peaked in the United States in 2001 due to COVID and has come down, but is still unacceptable. And what drives maternal mortality? Women's cardiovascular disease. We know that mental health is about 23%, which is part of the increased risk of maternal mortality. But if you look at cardiomyopathy, cardiac conditions, hypertensive disorders, and thromboembolic disorders, all of those have connections to cardiovascular disease. If you look back, the timing of death is actually not during the pregnancy, but actually after delivery, up to 7 days to 1 year, 53% of maternal deaths occur, compared to only about 1/4 during the day of delivery or during the pregnancy. And of course, I'm very passionate about this because I live in a state, Tennessee is number 50 in maternal mortality in the United States, but you can see throughout the Southeast, maternal mortality is significantly increased. And only in a few states do you see light green. Most those states are located on the West Coast, and then some of the states in the north central part of the United States have made significant progress. Well, pregnancy history matters, and we know that adverse maternal outcomes signal cardiovascular disease. This is due to the fact that pregnancy is basically a physiologic stress test. I tell my patients it's like getting on a treadmill, and you're going to increase your incline every month and the rate every month for 9 months. This results in significant stress on the maternal heart, which may manifest in hypertensive diseases of pregnancy, preeclampsia, including preeclampsia, placental abruption, stillbirth, and other complications. This pregnancy history is often overlooked when women go for their examinations. These are the adverse pregnancy outcomes that we often talk about. hypertensive disorders, gestational diabetes, placental abruption, small for gestational age infants, preterm labor, and one that is often overlooked, but a recurrent pregnancy loss. We feel that this is due to the fact that there is endothelial dysfunction and what we call ischemic changes in inflammation and vasospasm during the pregnancy that last long after the pregnancy and may be present prior to pregnancy. For this reason, the American Heart Association suggested that preeclampsia should be considered a failed stress test, which means that women who have preeclampsia are 2 to 4 times more likely to get cardiovascular disease later in life. Further recommendations are that we know that hypertensive diseases are associated with an increased risk of cardiovascular disease. And again, we should consider this not only a failed stress test, but a risk factor for future vascular and metabolic disease. If we look at long-term issues for heart disease, we know that patients with preeclampsia and hypertensive disorders are more likely to have heart failure, coronary artery disease, cardiovascular morbidity, including stroke, and one that many people are unaware of, long-term vascular dementia and end-stage renal disease. There's also an increased marker for diabetes, even though you may not have diabetes during the pregnancy. When we look at postpartum follow-up, what we see is that most women do not receive adequate postpartum care. Only about 64% receive, in this particular cohort, receive postpartum care. If the patient had gestational diabetes, only 29% received glucose screening. If they were elevated, we did even worse. We did not prescribe glucose-lowering medications or refer them for risk reduction. Patients with elevated blood pressure, we did a little bit better in giving those patients medications, but then we did worse in referring them for risk reduction, and the same for preeclampsia. And one of the things that we noted is that this particular study is that there were inadequacies in care, and that Black and brown persons were less likely to receive a referral. So again, the American Heart Association, in conjunction with the College of Obstetrics and Gynecology, decided to emphasize the healthy lifestyle and behaviors that should be a point of emphasis in the care of all women. Screening for cardiovascular disease and cardiovascular risk factors should be enhanced. Providers and healthcare systems should provide leverage technology to improve cardiovascular health for women, and that OBGYNs and cardiology providers should improve cardiovascular health care through enhanced collaboration. We're now going to go through some of the clinical research gaps that have been identified. As we already talked about, there's subclinical CVD screenings is unidentified. We don't know who to target. We don't know what adverse pregnancy outcomes, except for hypertensive diseases, have had the most, or may be associated with the most, severe outcomes. And again, as I pointed out, advanced pregnancy issues, advanced disorders of pregnancy, perinatal disorders are not often factored into CVD risk. And in a recent nurses study analysis, they found that adverse perinatal outcomes, only if we even put it in, provided modest improvements for the discrimination of premature CVD. There are also care gaps. There's inadequate postpartum CVD counseling, as I pointed out, fragmented care transitions. OB records are often not included, or they're siloed in the patient's chart. There's delays in transfers of care between the obstetrician and the primary care provider. We know that insurance coverage gaps, many states have not expanded Medicaid, are an issue. And then there is the delay or misdiagnosis of CVD, as many studies have noted that in pregnancy, it was not known until the patient died in 50% of the cases, and in only 3% of the cases was CVD known. There's no standardized screening tool, although there are some that are recommended, and screening is not universally required during pregnancy. This is the screening tool that is from the California Collaborative. And what we see here is that this is a very simple tool in which we look at symptoms, vital signs, risk factors. Notice that risk factors alone can give the patient a positive screen. Being over 40, being African American, BMI greater than 35, pre-existing high blood pressure, diabetes, substance use, all substances, including tobacco and alcohol, and a history of chemotherapy. But remember what I just said, only 3% of patients wasn't even known that the patient had heart disease prior to their death. And adding in with one from each of one of these boxes for a combination of 3 or 4 total. The other thing that we're encouraging is physical exam. Often, physical exam is not performed in women of childbearing age. Once we know that the patient has a positive screen, we can recommend then testing. Simple lab results and an EKG, followed by other echo, an echo or an ultrasound of the maternal heart, is a great way to rule out underlying cardiovascular disease and does not stress the healthcare system. If the patient is negative, that also provides an opportunity for us to counsel about modifiable risk factors. Well, what is the evidence for building the evidence for the postpartum year? I just laid it out for you. And what we do know is that these transitions, these cross transitions don't occur. And one of the things that we really talked about is the fact is that HRSA, the NIH, and other sponsors should support a full spectrum of research to reduce adverse pregnancy outcomes during the first 12 months after delivery. We think that once the baby's out, it is all good. And we know that that is hurting women. There are also research gaps, cross-cutting conclusions. This is from the National Academy of Sciences. We need outcomes that matter. We need standardized measures. We need long-term follow-up, and we need implementation science that reveals evidence on sustainable technology such as telehealth, workforce models, reimbursement, and partnerships to access and follow up. Well, we do have some novel strategies in pregnancy and postpartum since it's an opportunistic window for CVD assessment, So most recently, there's been a study with highly sensitive troponin and SFLT measured at 39 weeks. We know that elevated levels during this time was independently associated with the CVD risk over an 11-year follow-up and improved detection over traditional CVD risk factors. There are also other things that we should be doing that we currently aren't doing on a regular basis, such as coronary artery calcium scoring. A meta-analysis showed in 35 studies that the risk was higher for subclinical atherosclerosis in patients with prior preeclampsia. Echo remodeling has been shown to occur in the heart, and especially in the left ventricle, for up to 10 years after the hypertensive disorder of pregnancy. We currently use a test, SFLT and placental growth factor, to predict preeclampsia, but it's also associated with subclinical myocardial dysfunction. And most importantly, one of the things we've been doing better is looking at a longitudinal global strain, because even if your ejection fraction is normal, there may be some early impairment of the heart. There are also some pharmacologic strategies. We know that metformin reduces the incidence of diabetes at about 50% at 3 years and 40% at 10 years in patients with prior gestational diabetes. And adding a GPL1 or GPL2 inhibitor may have additive benefits. Low-dose salicylic acid after severe preeclampsia. There's currently a trial going on to determine whether endothelial dysfunction can be affected. We know low-dose salicylic acid during pregnancy may reduce the risk of preeclampsia. And statins have also been endorsed as risk enhancers for primary prevention of adverse pregnancy outcomes. We do know that it prevents preeclampsia and intermediate 10-year risk factors. And this is one of the ones that is near and dear to my heart, breastfeeding as a cardiovascular intervention. The meta-analysis of 8 prospective studies. Breastfeeding lowered your CVD risk by 11%, your risk of congestive heart failure by 14%, your risk of stroke by 12%, and there was a 17% reduction in fatal CVD. And what we know about this is that this is progressive reduction up to 12 months. So women who breastfeed 3 months, it's better than breastfeeding none. And women who breastfeed 6 months is better than breastfeeding 3 months. Up to 12 months, we see this a reduction, and should be something that we're counseling our patients about who are in the postpartum period. They're also shown in the 2025 HAPO follow-up. This is a study looking at diabetes, a protective effect of breastfeeding in patients with previous gestational diabetes. And the Cardia study showed that up to 3 months after lactation greater than 3 months was associated with a favorable cardiometabolic profile, for 30 years after follow-up. So this is a great opportunity in the postpartum period. We do want to talk and acknowledge structural racism and social determinants of health. Black women face the risk of dying after pregnancy or during, that is, as we pointed out, much higher than white women or Hispanic women. Even after adjusting for socioeconomic status, access to care, and other conditions, there's still an issue. More likely to die, 45% more likely to die in the hospital, 23% more likely to die of a heart attack, 57% more likely to die of a stroke, 42% more likely to have an embolism, and 71% more likely to have congestive heart failure. We must do research in this area to figure out why that is. There may be some healthcare and access and quality issues. It's really interesting. Black women were 4 times less likely to receive adequate prenatal care and more likely to deliver it in hospitals with high maternal mortality rates. The lack of Medicaid expansion disproportionately affects Black and brown women, but if you notice, Hispanic women do not have the same maternal mortality rate. And then, of course, there's residential segregation and neighborhood environments, maternity care deserts, and poor access to internet, which we have here in the state where I live, which often limits telehealth options. So very quickly, I'm going to talk about research priorities to strengthen our base. We really need to think about developing core outcomes and consistent definitions for pregnancy-related cardio studies, and prioritize health outcomes and strongly link them to intermediate outcomes. It would be great if we could establish a national research network across diverse settings to enable multi-center studies on severe maternal morbidity and mortality. We also need to think about looking at, like we talked about before, a substantial share of deaths occur postpartum. How do we leverage this? How do we allow HRSA, the NIH, and other areas to help us develop outcomes and strategies for the period during the 12 months after delivery, when most of our maternal mortality occurs. In the recent report of the National Academy of Sciences, Engineering, and Medicine, we looked at a number of things and to determine whether or not there was significant evidence to decide whether these were very helpful in reducing intermediate outcomes and long-term outcomes. And what I have talked about today, we know that calcium scoring, some type of wearable device, remote blood pressure monitoring, breastfeeding, and again, metformin after gestational diabetes have significant effects. There's also work, but not good work, on Life's Essential 8, and it would be great to have more data around implementing it before and after pregnancy to determine whether it reduces issues with outcome. And as you know, Life's Essential 8 has to do with controlling your blood pressure, getting plenty of sleep, stopping smoking, lifestyle changes, exercising, which are applicable to all of us. So these are the recommendations for closing gaps. Structured screening timeline using Life's Essential 8 framework, for CVD risk factor assessments at 6 weeks, 12 weeks, 6 months, and 12 months postpartum, which means patients have to have insurance for access. ACOG also recommends within 3 months postpartum, we screen patients with severe pregnancy outcomes. Multidisciplinary cardio-obstetrics teams have shown to actually reduce adverse cardiac complications during pregnancy and represent a key model for bridging the gap between obstetric and cardiovascular care. Expanding those teams is important to make sure that the patient gets postpartum care as well. We've talked about remote blood pressure monitoring, and digital health interventions, and then implementing community interventions through doula care and community healthcare workers. I realize this has been like a lightning fast thing to talk about because has been a place where we have not put a lot of emphasis. I appreciate your time, and I look forward to sharing with you during the question and answer session.
Thank you so much, Dr. Graves. That was a really great presentation. Next, we have Dr. Emily Lau, who will discuss cardiovascular health at midlife, particularly during menopause. Thank you for joining us, Dr. Lau.
Well, thank you so much for the invitation and to be part of this tremendous panel. I'll be talking about cardiovascular health around the time of midlife and menopause. These are my disclosures that are unrelated really to the topic of today's talk. So before we delve in, I want to start with this masterpiece from 1959. Imagine being happy during the change of life. Well, nothing really says women's health quite like a newspaper ad that treats menopause like some sort of mysterious condition that you can cure with a tablet and a brave smile. Menopause really is the biggest life transition that nobody bothered to put in the brochure. And interestingly, I think we all know that menopause is really having its moment now in 2026. We've seen menopause everywhere in culture lately. Podcasts, influencers, wellness aisles, but still oddly absent from medical training and specifically from cardiovascular conversations. And yet, with rising life expectancies, most women today will spend up to 40% of their lives in menopause. Now, most of us know that menopause is the permanent cessation of ovarian function, and it begins after a woman has gone 12 months without a menstrual cycle. But why am I, a cardiologist, talking about menopause? Well, it's because menopause is also a time of accelerating cardiovascular disease risk. Up until menopause, cardiovascular disease risk in women lags significantly behind men. But then we see that quickly quickly after that menopause transition, women's rates of cardiovascular disease really start to accelerate. And we've seen that during the menopause transition, women experience several changes, adverse changes in several lipid and lipoprotein measures that have been linked to greater risk of cardiovascular disease. Displayed here are data from the Study of Women's Health Across the Nation, which is a prospective study of the menopause transition in about 3,300 women. And as you can see, there are substantial increases in total cholesterol, LDL cholesterol, and apolipoprotein B within the 1-year interval before and after the final menstrual period. And these changes are really thought to be beyond what we would expect to see for changes in chronologic aging alone. Now, the relationship between menopause and HDL cholesterol appears to be more complex. While we do see a slight decline in HDL cholesterol levels following menopause, prior work from Swan suggests that there might be an apparent reversal in the direction of association between HDL cholesterol and cardiovascular disease risk, with higher HDL cholesterol levels associated with less carotid atherosclerosis before menopause, but with greater carotid atherosclerosis after menopause. And in Swan, the investigators found that during the menopause transition, HDL function, as measured by HDL cholesterol efflux capacity per HDL particle, actually declined. So basically, HDL particles became less efficient in promoting cholesterol efflux. And this may explain why HDL cholesterol over the menopause transition was actually associated with progression of atherosclerosis, which is really contrary to how we think about HDL cholesterol in general prevention. Now, what about weight? I'm sure many of you have had patients tell you, midlife women patients tell you about how they've suddenly put on weight around the time of menopause. Well, it turns out that midlife weight gain is actually not really due to menopause. In two studies of midlife women, SWAN and another study called the Healthy Women Study, investigators followed midlife women for 3 years, and they found that women on average gained about 2 to 2.3 kilograms over that time period, but that there were no appreciable differences observed for women by menopause status. What we do see, however, is a change in body composition. The SWAN study showed us that fat mass and visceral adipose tissue markedly increased, while lean mass declined during the perimenopause period. So using DEXA scans, the SWAN investigators examined change in body composition over 18 years across the final menstrual period. 2 years before the final menstrual period, the rate of fat gain doubled and lean mass declined, which continued until about 2 years after the final menstrual period. And this really suggests that the accelerated gains in fat mass and losses of lean mass are in fact menopause-related phenomena. And these changes in visceral adipose tissue are in fact associated with markers of subclinical cardiovascular disease, including carotid artery intima media thickness. As you can see here, changes in carotid intima media thickness mirrored the trajectories for visceral adipose tissue. So there's essentially no change in carotid IMT before 2 years prior to the final menstrual period, followed by an accelerated increase in carotid IMT during the perimenopause period, and then finally a slower increase in carotid IMT after the final menstrual period. So for many years, absence of ovarian estrogen following menopause was hypothesized to explain all of these adverse changes in cardiometabolic health that we just reviewed. And this was really further supported by observational data that showed that postmenopausal estrogen therapy was associated with markedly lower rates of major coronary disease and fatal cardiovascular disease. However, as you may all recall, the landmark WHI and HERS trials demonstrated that administration of estrogen therapy for both the primary and secondary prevention of cardiovascular disease did not reduce cardiovascular events. In fact, in the WHI, hormone therapy paradoxically increased cardiovascular events, specifically venous thromboembolism and stroke. So together, these findings effectively refuted the prevailing hypothesis at the time that estrogen deficiency alone explained the acceleration of cardiovascular disease observed in women following menopause. Now, it turns out the cardiovascular effects of hormone therapy is also influenced by when menopausal hormone therapy is initiated. Specifically, menopausal hormone therapy may actually reduce cardiovascular disease events if initiated in women less than 60 years of age or less than 10 years since menopause. So when the WHI investigators went back and looked at their data, age-stratified analyses with longer cumulative follow-ups supported a more nuanced approach to hormone therapy. These analyses demonstrated that the absolute risks of adverse events after hormone therapy initiation were much lower for younger women, those between 50 to 59 years of age, than for older women, and for those who initiated hormone therapy within a decade of menopause. Now, building on these data, two randomized trials tested this so-called timing hypothesis by examining the effect of menopausal hormone therapy on subclinical cardiovascular disease in younger postmenopausal women. The KEEPS trial, which included only women within 3 years of menopause, found no significant increase in carotid intima media thickness with menopausal hormone therapy. The ELITE trial found that low-dose oral estradiol reduced carotid IMT progression in women who were less than 6 years postmenopause, but not in women who were greater than 10 years postmenopause. So right about now, many of you may be scratching your heads asking the question, so where does that leave hormone therapy? And to answer that question, I think it's helpful to review how we got here. Menopausal hormone therapy use began during the Great Depression when Premarin first emerged on the market for the treatment of hot flashes and other vasomotor symptoms in menopausal women. But then enthusiasm waned in the mid-1970s when scientists discovered the link between endometrial cancer and unopposed exogenous estrogen therapy. Fortunately, by the mid-1980s, it was clear that adding a progestogen to estrogen reduced endometrial cancer risk. And then in the 1990s, observational data like the Nurses' Health Study found that estrogen was associated with lower risk of cardiovascular disease. And this fueled a dramatic increase in menopausal hormone therapy prescriptions. By the late 1990s, there were over 90 million prescriptions for hormone therapy per year in the United States. Now, cracks in the armor began showing in the late 1990s with the publication of the HERS trial that showed no reduction in cardiovascular events for the secondary prevention of cardiovascular disease. But the nail in the coffin occurred in 2002 with the publication of the WHI results. Hormone therapy prescriptions plummeted, and even after the publication of the KEEPS and ELITE trials, hormone therapy is prescribed to only about 3 to 4% of peri and postmenopausal women today, which translates to about 10 to 15 million prescriptions per year. Now, menopausal hormone therapy got a lot of press this past year, so much so that even cardiologists have been asking me about it. So what happened? Well, in November of 2025, the FDA, along with HHS, announced a major labeling change for menopausal hormone therapy, and they began the process of removing the class-wide boxed or black box warning language from menopausal hormone therapy products. This included both systemic and vaginal. And these warnings had broadly warned of increased risks of cardiovascular disease, breast cancer, and probable dementia. Now, so that's what changed. Well, what didn't change? What hasn't changed is that menopausal hormone therapy should still be used for symptom management, and that initiation should still be guided by individualized risk-benefit assessment. And finally, and really importantly, menopausal hormone therapy is not indicated for either the primary or secondary prevention of cardiovascular disease. So what does menopausal hormone therapy look like in 2026? Menopausal hormone therapy, often also commonly referred to as hormone replacement therapy or HRT, although that terminology has somewhat fallen out of favor, is treatment that's targeted at the relief of menopausal symptoms and not for the prevention of cardiovascular disease. The 4 FDA-approved indications for menopausal hormone therapy at present include relief of vasomotor symptoms, prevention of osteoporosis, premature hypoestrogenism, and for the genitourinary syndrome of menopause or vulvovaginal atrophy. Menopausal hormone therapy usually consists of either estrogen alone for women without a uterus and estrogen in combination with the progestogen for women with an intact uterus. And there are 3 major formulations: oral, transdermal, and vaginal. Oral and transdermal estrogen are considered systemic hormone therapy with similar efficacy and better safety profile in transdermal formulations. Vaginal estrogen is minimally absorbed and is primarily used for the local treatment of vulvovaginal atrophy. Now, of note, there's an estradiol acetate vaginal ring on the market that does deliver systemic doses of hormone therapy. Now, the cardiologist's role is really to help determine whether menopausal hormone therapy is safe for an individual patient with one of the 4 FDA-approved indications. To do that, we look at 2 elements: years since menopause onset and 10 and 10-year ASCVD risk. For women who are less than 10 years postmenopause and low ASCVD risk, hormone therapy is thought to be completely safe, either oral or transdermal. For women who are less than 10 years postmenopause with intermediate ASCVD risk, we think that hormone therapy is okay, but we really do prefer the transdermal formulation in this population. For women who are greater than 10 years postmenopause and either low or intermediate ASCVD risk, we recommend considering alternatives and avoiding systemic hormone therapy if possible. But if an individual patient is experiencing severe vasomotor symptoms or other menopause-related symptoms, this is where an individualized shared decision-making discussion comes into play. And finally, for all women who are high risk, doesn't matter years since menopause onset, we really do recommend avoiding systemic hormone therapy. Now, you have assessed your patient's overall risk profile and you've determined that risks of menopausal hormone therapy outweigh benefits. Well, what now? Are there other options for our high-risk patients? And the answer to that question is yes, there are numerous non-hormonal alternatives that have all been shown to improve vasomotor symptoms, albeit not as effectively as systemic hormone therapy. These include lifestyle measures, antidepressants like SSRIs and SNRIs, gabapentin, and oxybutynin. And excitingly, there are 2 new non-hormonal therapies that may be a real game changer, and they are called fezolinetant and elinzanetant. Fezolinetant is a novel neurokinin 3 receptor antagonist that was approved by the FDA in 2023 for the treatment of moderate to severe vasomotor symptoms. And elinzanetant is a combination neurokinin 1 neurokinin 3 receptor antagonist that was also approved by the FDA for the treatment of moderate to severe vasomotor symptoms just recently in October of 2025. So, just to end on a few take home messages, the first is that menopause is a time of accelerating cardiovascular disease risk. We talked about a number of adverse changes in cardiometabolic traits that occur during this life transition, including adverse changes in lipid and lipoprotein profiles, body composition. And that's, I think, a really important piece to understand. And the second is that menopausal hormone therapy increased risk of cardiovascular disease in randomized trials, but are safe in women who are less than 60 years of age and less than 10 years post-menopause if the cardiovascular disease risk is either low or intermediate. And finally, we recommend transdermal estrogen in women with intermediate 10-year estimated ASCVD risk. And on that note, thank you so much for having me as part of this symposium, and I look forward to our panel discussion.
Thank you so much, Dr. Lau. I was saying thank you, Dr. Lau, for joining us. And please note that those who are tuned in live can submit questions at any time using the Q&A function, and we'll try to address as many as we can during the panel portion, a discussion of today's program. So now let's please welcome Claire DeAndre, who will be sharing about living with cardiovascular disease. Thank you for joining us, Claire.
Thank you. Okay. Hi, everybody, and thank you for inviting me to be part of this amazing program. Listening to Dr. Graves and Dr. Lau made me think about my time going through my life changes and having my own children. So I'm here to talk about my heart story, which is Dear Heart, I Am Listening Now. And I titled that because I've had a couple of episodes in my life that really were life-changing for me. And I want to share them with you so you can all understand what it's like living with heart disease. So I am a mom, I am a daughter, a sister, an aunt, a nurse, a wife, a mother, a health coach, a healer, a friend, a grandmother, and I'm also a women heart champion, and I'm a survivor, just like the rest of you. The journey of my heart started in Massachusetts in 1996, and after Dr. Graves' lecture, I was thinking about when I was pregnant, and I think I was never told I had preeclampsia, but I remember my blood pressure going up a little bit a couple of times. So now I'm reflecting on that as part of my journey. But I was a busy mom working with two teenage daughters, and I had a 12-year-old son, and I was really busy taking them to places, dancing, skating, soccer, school, and I really had no time for rest and self-care because I was working as a home health nurse and driving all over the place. The kids went to schools outside of our town, so I was actually driving them to school every day as well. At the age of 42, I did develop high blood pressure. My signs for that were visual disturbances. Actually, while I was seeing a patient, I was in their house and I had flashes in my eye and I had a headache. So I immediately went home and took my blood pressure, and it was high, and I went to the doctor. I'm a good compliant nurse and patient. I did a 48-hour blood pressure monitor during a very stressful period of time, and I definitely had consistent high blood pressure. So they wanted to start me on medication, which I did. That same year, my husband's company closed down. And there was a loss of income in our house, which mandated that I needed to work more hours to help us out. He didn't have a job for a year, but he was home helping, taking care of the kids and doing the carpooling which took off a little stress from me. However, he couldn't get a job in Massachusetts, and he ended up moving to the West Coast. We didn't want to move, but we had to eventually. In 1997, I like to look at that as a year of transition in my heart journey. I continued to work full time. I still managed the house and the kids. I was prepping the house for sale with painting and getting the real estate broker and showing the house and doing all of that, still doing all the other activities with the kids while my husband was living in California. We each we went to California a couple of times to visit. We also had him come home a couple of times a year, but it was a very stressful year, as you can imagine. That year, I developed jaw and neck pain. and it was left-sided jaw pain. And I went to the dentist, and the dentist basically said I had an abscess, so I had root canal. But after the root canal, the pain remained in my jaw. So I went back to the dentist and I had oral surgery. They cut open my jaw to backfill where they had done the root canal. And lo and behold, the pain still remained. So that year, I continued to live on Tylenol and sometimes taking a leave. I didn't really have time to go and explore if there was anything else wrong with me, and I had no feeling that it would be heart disease for me. I also experienced a lot of fatigue, and I had tight muscles in my shoulders and in my neck, but I thought it was stress related for the workload and the prep for the move and dealing with my own emotions and the kids. That year, my one daughter graduated in June of 1997, but that my other daughter had to leave her senior year, which you can imagine was very stressful. None of us wanted to move, but we definitely had to. In August of 1997, we moved, and it actually was fun to move to an area that wasn't cold and wet and snowy all the time. So we tried to look at it as an adventure. We did move into an older home, which required a lot of work on our part, but we also ended up having a lot of neighbors. We had lived in the woods and lived naturally before. I grew all my own vegetables. I baked all my own bread. So we tried to live very holistically for quite a while. I was busy getting the kids into their new schools for the seventh grader and my 12th grader, and my eldest decided to go to college in San Diego so she could be near us, and she started dancing professionally. So we explored new sports teams, got my daughter a new skating coach. I had to get physicians, dentists, all these things that we do for our children, but I didn't do them for myself right away. I was too busy wanting to integrate all of them. My jaw and shoulder pain continued, and the fatigue definitely increased. I also began to feel short of breath on exertion, and I tired easily. Certainly, the stress was way more than it had been. So the heart speaks. Are you listening? And I think our heart speaks to us and our body speaks to us in many ways, and we don't stop to pay attention to what it's saying. And those are things that I've learned to do over these decades of living with heart disease. I still had jaw and neck pain when we lived in California. The fatigue worsened, and I became short of breath climbing stairs. And I also began to experience episodes of indigestion I thought was related to coffee and orange juice. My self-talk was, I am stressed. This was a stressful year. This is causing my symptoms. I'm out of shape. I need to eat better. I need to work out, take care of myself more, and give myself a little self-love, which I really didn't do. I stopped drinking coffee and orange juice due to the indigestion, and I thought it was too acidic, but I noticed I still had the indigestion. I started walking the hills by our house regularly, but they were really tiring for me to do. I actually, being a nurse, had been looking for a job, and so I was busy doing that as well. But one night walking, my heart spoke loudly, and I had to stop. I was forced to stop and listen. While I was walking the dog up a hill, I had excruciating pain between my shoulder blades. And that went all the way into my chest and it radiated all through my upper body. You know, as a nurse, I was never trained about young women having heart disease or even women having heart disease because I was always told that it was a man's disease. And that certainly has changed my life dramatically. So that pain stopped me in my tracks. And I waited for it to subside and slowly walked home. When I got home, my husband and I were saying, "Oh, I'm probably just out of shape and I need to really work out more and I'll feel better." But I really began to think that it could be my heart. However, there was no family history of early heart disease. I was only 45. I had never smoked. I wasn't overweight. I didn't have diabetes, and all my labs were normal. At that time, my LDL was actually 99, which was really great for me. So it was time for action for me to seek care. So in January of that year, I finally established care with a PCP who was a female who really listened to me. She did an EKG, which was normal, and I was grateful for that. I hadn't had a heart attack, but she did refer me to a cardiologist. However, I didn't make the cardiology appointment immediately because I had a new job doing cardiovascular research at a local hospital running the clinical trials, and I had to travel for work. So I was running through the airport, and once again, I was stopped dead in my tracks with that pain between my shoulder blades. But I still kept going. I slowly walked to the airplane. I got on the plane and I made the trip. When I returned home, I finally made that cardiology appointment. I saw my cardiologist on a Friday. She was a woman and she listened carefully to my symptoms and immediately scheduled me that day for an exercise stress test. I failed within 3 minutes of walking on that treadmill. And being a cardiac nurse, I could see my EKG and I knew how bad I was looking at my ST segment elevations. I was immediately put on a table, given nitro, given aspirin, put oxygen on me. It was really, really scary time for me. I do recall the blazing headache from the nitro and the oxygen, and I felt really scared. I was given a prescription for nitro and told to go home because they couldn't get me into the cath lab that day. And I was to call 911 if that the pain had returned. I was told also not to do anything. I was told not to do laundry, not to carry laundry, not to do anything. And I didn't do it for the first day, but after that, I just continued to do my work around the house. That Friday, I went home and cried. I was afraid I was going to die. I was afraid my kids would be without their mom in this new state, this strange land, and our new home. So my husband and I decided not to tell them anything about it. And we didn't tell them about the pending angiogram. On Monday, March 31st, and it just remains in my mind for that day all the time, 1998, they all went off to school and we went off to the cardiac cath lab. Interesting, I used to work in a cath lab back in New Jersey a long time ago, and I used to assist with the cardiac angiograms. So I knew where I was going and what I was doing. I could see the images on the screen, and when I saw them inject my coronary artery, I knew that I was really, really lucky to be alive. So I had a blocked coronary artery in my left anterior descending, and they put a stent in. I can tell you that prior to stents, my option would have been bypass surgery. So I am really grateful for research and the invention of stents. I spent the night in ICU, and I was forced to tell my kids that day as they stood there looking at me as I lied immobile in this ICU bed. It was a turning point for all of us. I realized then that my shoulder and jaw pain were gone and that taking a deep breath was really easy now. So I believe all along that those symptoms were heart related. So my life began anew with gratitude and self-care practices. I started listening to my heart. I became actively engaged in lifestyle change for my body, my mind, and my spirit. Exercise became a really important part of my life. I changed my diet. I stopped eating red meats. I cut out butters and fats. I was put on a statin, and I had already been on medication for my heart. So those were the two main medications I was taking. I started learning to meditate and journaling. I was compliant with my medications, and I actually started a new job with my cardiologist in 2002, and my role was teaching others in lifestyle change. And then afterwards, I managed the entire department, which we did stress testing there as well. I joined Women Heart in 2004 and trained as a champion, and I started a support group there. I look at healing journey as like riding a wave. Sometimes we do really well with our lifestyle change and our stress management, and we're on top of everything. And other times things come crashing in around us. So I had another wake up, shake up in 2012. My cardiologist listens to my carotid arteries, and in 2010, it was 50% occluded based on a echo they did on my carotid. So we did echoes every 3 months on my carotid. But I was in a very stressful job. I obviously wasn't managing my stress as well as I should have been. And in 2 years, my carotid went from 50% occluded to almost 100% occluded. I ended up having to go in for a blocked carotid artery surgery called endarterectomy. They cut open the right side of my neck and they pulled out the plaque. So that was a wake-up call, number two for me, and I was blessed to be alive. So I look at it as dear heart. I'm listening to you now. And I want to just add that I have also had genetic testing done. And even after I had my stent, my genetic testing said I was at average risk for heart disease. So I look at the lifestyle change as an important part of me for managing my health and my cardiovascular health. So, dear heart, I still am listening. Self-care isn't selfish, it's self-love. Lifestyle change is lifelong and should include body, mind, and spirit. Life is filled with our daily challenges. We need to engage in mindful practices to cultivate resiliency. We have to practice them every day. And if we don't, it's okay. Just go back and start them again. I do yoga and breath work and guided imagery. I have social support through friends, but also through women's groups such as Women Heart. We need to advocate for our own health and develop a partnership with your healthcare team. Consider enrolling in research trials to advance women's health. We need more women in research studies. We need to advocate for healthcare policy changes for women, and we need to shift our perspective in life. For me, it was like I felt like I was given a bad rap, given lemons, and I needed to sweeten it to make lemonade, to find a way to move forward with gratitude instead of anger or resentment or bitterness. So I find gratitude and joy in each day, and I enjoy life. So we all have to be still, take time for ourselves, and get to know ourselves, know our body, because our heart speaks, our body speaks. Are we each listening? Are you listening? I am blessed. When I first had my stent, I wanted to see my son, who's on the picture here, graduate eighth grade, and my daughter graduate high school. They all now have their masters. They're all married. We've been through marriage and divorce. I had two beautiful grandchildren. I now have a step granddaughter and a step grandson. And I want to thank you all for this time. I think what you're all doing is quite amazing. Thank you to the Society for Women's Health Research and for Women Heart for all you do. Thank you.
Thank you so much, Claire. Our final panelist today is going to be Madeline Adams, who will lead us in a conversation about policy in women's cardiovascular health. Thank you so much for joining us, Madeline.
Of course, thank you so much, everybody. Before I get started, Sarah, can you confirm for me that you can see my screen?
I can't see your screen.
You can?
Yes.
Okay, perfect. Thank you so much. Hi, everybody. My name is Madeline Adams, and I am the Public Policy and Advocacy Manager with the Society. In a follow-up to the incredible presentations before me, we'll spend the next 15 minutes or so discussing the role that policy and advocacy play in shaping women's heart health outcomes, including some ways in which the audience attending today's session can get involved. As the other presenters before me have emphasized over the course of today's session, when we think about heart health, we don't always think about it as a women's health issue, but it absolutely is. This gap in framing is concerning, given that 44% of women are living with heart disease, and heart disease is the leading cause of death for women. Many women aren't aware of this fact, and relatedly, many women are not aware of the risks for developing heart disease or what their symptoms might be. This lack of awareness is present across the lifespan, and there's an urgent need to address gaps and barriers with respect to research, access to care, quality of clinical care, and general public awareness and education around women's heart health. To drive this point further, and to get to the heart of today's symposium, I want to spend a couple minutes emphasizing women's heart health across the lifespan. Before me, you heard Dr. Graves discuss the impacts of pregnancy and postpartum, and Dr. Lau spoke to midlife and menopause as critical entry points for research. And Claire, more recently, spoke to some clinical awareness gaps in accessing care in her journey, and I have to agree with all of the points that were made. What I'm gathering throughout today's conversation is that we do see clear opportunities across the women's lifespan where policy can play a role in improving outcomes. Let's take it back to pregnancy, for instance. For many women, this might be their first interaction with the healthcare system as adults, making it an incredibly important entry point for cardiovascular health education and prevention. This is especially true given that pregnancy is a moment when a woman's health is highly visible, meaning that it's a time when underlying or previously undiagnosed conditions like hypertension, lipid disorders, or even glucose intolerance may become more apparent or even be exacerbated by pregnancy. And importantly, it's also a moment when many women are highly engaged and motivated to understand their health and to learn those strategies to stay healthy in the long term. Ultimately, they want to be healthy and they want their babies to be healthy too. And so we can see a lot of ways in which policy interventions can play a role in improving maternal health care. Meanwhile, women's midlife and menopause is also a major transitional time for entry. 1.3 million American women transition into menopause each year. Hot flashes, night sweats, depression, other symptoms during menopause are associated with greater cardiovascular disease risk and other heart-related health problems. Inevitably, every single woman will go through menopause. It's unavoidable. And yet we don't think of it as an opportunity for addressing women's heart health, and research and policy can and should be addressing this critical life stage. Finally, bringing us to older age, this is when underlying and chronic health issues may become even more exacerbated. More than 76% of women ages 60 to 79 have some form of cardiovascular disease, and this statistic increases to 85% for those aged 80 and older. It is at this time that Medicare coverage is critically important, and patients need and deserve to be equipped with the information they need to have candid conversations with their healthcare providers about their risk factors and implementing heart healthy habits. And this stage becomes even more critical for those conversations. So, taken together, all of these facts make clear that there's ample opportunity across a women's lifespan for improved research and for healthcare providers to support women's heart health. And the fact of the matter is also that women's cardiovascular and heart health outcomes are shaped by policy decisions long before they might even enter a clinic or start experiencing symptoms. And so, in thinking about our policy approaches to women's heart health, the issue is clearly multifaceted. And while a number of barriers exist, I like to think of it from a three-pronged approach. Those three prongs being research, patient access to care, and improved clinical care and awareness. From a research perspective, we know that women have been under-researched for decades. That's the whole reason why the society and our partners exist. And so while the tides are turning, there are still ongoing research gaps when it comes to women's health and women's heart health specifically. Women make up just about 24% of heart failure trials, and women under the age of 55 are nearly twice as likely to die in the hospital from a heart attack compared with men of the same age group. Imagine how improved research could serve as an intervention there. You know, those lifespan factors like the menopause transition also remain funded and understudied, and that area warrants greater research investments. Ultimately, an ongoing lack of research hinders our ability to understand how those factors like sex and gender might intersect with other factors like age, race, ethnicity, socioeconomic status, where somebody lives, their geography, and shaping cardiovascular outcomes. And so I ask, how can federally funded research be supported to investigate the impact of these factors? In terms of access to care, we know that access to comprehensive health care, treatments, and medications play an important role in supporting women's heart health throughout the lifespan. From preventative care in early adulthood to managing chronic conditions later in life, having ongoing and uninterrupted access to quality health care allows women to make informed health decisions at every stage and to access the care that they need. And then finally, from a clinical care perspective, this is where things might get a little bit more complicated and these solutions might not be as straightforward. But a key challenge is the fact that women's heart health symptoms are still often described as atypical, when in reality, they're well-recognized presentations in women. They're just not necessarily reflected maybe in the historical clinical standard, which has been largely based on male data. And so We know that women might present with fatigue, shortness of breath, nausea, back or jaw pain, rather than the classic chest pain that has traditionally anchored diagnostic frameworks and that we see portrayed across media and in movies and whatnot. And so, from a policy perspective, this is not just a clinical awareness issue, it's actually a broader systems issue. It's really a reflection of how medical education is structured, how competencies are tested, and what gets reinforced through clinical guidelines. If you didn't already know, research does show that women are less likely to receive guideline-directed therapies and interventions for heart disease compared to men, even though those guideline-directed therapies do exist. And so I have to ask if training, board examinations, and continuing education continue to prioritize male pattern presentations as the default, then I imagine that the diagnostic bias is being effectively built into the system. And so maybe addressing this issue requires embedding sex and gender specific content into core medical curriculum and licensing exams, not just as supplemental, nice to have material, but as foundational knowledge. And I also want to take a quick moment to acknowledge the fact that although 44% of women in the US have some form of heart disease, women account for only about 13% of cardiologists. Even more, Dr. Graves earlier had spoke to some of the disparities that we see in heart disease. We know that Black women are subject to disparate impacts of heart disease, and yet Black women account for less than 4% of heart cardiologists. So clearly we have a workforce issue in that sense. And I do want to acknowledge that there are a lot of talented and caring male cardiologists out there, and thank you for that. But imagine what it might look like if we have improved representation of women of all backgrounds in these healthcare specialties. So the point I'm making here is really that the goal is not to create a separate standard for women, but to correct a structural gap in how cardiovascular disease has been defined and operationalized in clinical practice. So clearly, there are several broad systems level policy related opportunities and approaches. And the good news is there are several pieces of legislation being considered before Congress as we speak. A handful of them I would like to talk through very quickly here today. So the first one that comes to mind is the Women's Heart Health Expansion Act. In case you are not already familiar, the CDC runs a program called WISE Women. This is an acronym that stands for Well Integrated Screening and Evaluation for Women Across the Nation. The program helps women ages 35 to 64 check their heart health and lower their risk for heart disease and stroke. The program is designed to make care easier for access and support women from different communities across the country. This bill would essentially just reauthorize the program and expand access to the program by funding even more heart health screenings, putting more money into education, and also encouraging more treatment referrals for low-income women and increasing access to these services nationwide through additional grants and long-term federal spending. The Safe Step Act is another bill that presents a major opportunity. This legislation is actually modeled after state legislation that has been passed across several states related to step therapy, or otherwise known as Fail First, policy for prescription drug coverage. The act would make it easier for patients to get exceptions to step therapy rules by requiring employer health plans to offer a clear appeals process and to also respond in a timely manner within 72 hours when a doctor or provider says that a different treatment is needed, and that timeline is expedited to 24 hours if a patient's life is at risk. We also have the Clinical Trial Modernization Act. This bill is basically just trying to make it easier and more affordable for people to join medical research studies, especially those from communities that are often left out of our existing research standards. This might include those populations like caregivers, rural residing patients, older women, and underserved populations who often face barriers in several different ways to participating in medical trials. If passed, the bill would require the federal government to fund programs to help researchers reach and recruit those populations. And it would also allow researchers to cover things like travel or other participation costs, health technologies like devices, and insurance copays or other out-of-pocket medical costs related to the trial. Two other bills that I want to briefly highlight, which may not at first glance seem directly tied to women's heart health, but they speak to the broader reality that women's health needs evolve across every life stage. So the first bill would be the Advancing Safe Medications for Moms and Babies Act. The act could be viewed as a way to support women's heart health by ensuring that pregnant and postpartum women are safely included in clinical research and medication studies. Cardiovascular disease, as we know and as we have established earlier in today's conversation, is a leading cause of maternal mortality in the United States. And yet there are major gaps in data on how heart medications and treatments might affect pregnant and lactating patients. And we want to be protecting those patients through research, not from research. And so by improving the research standards and expanding evidence on medication safety, the bill really could, by extension, help clinicians better treat those conditions like hypertension, preeclampsia, and other cardiovascular complications during and after pregnancy. And then finally, we have the Advancing Menopause Care and Midlife Women's Health Act. This legislation invests in research, provider training, prevention, and public awareness, helping ensure that women are receiving earlier screening, better care, and more accurate diagnosis during women's midlife. As mentioned several times now, menopause is a critical intervention point. The research and training that would be supported by this bill could help extend to improved identification of cardiovascular risk factors that might come about during that midlife stage. And so I share these bills as a handful of examples of what's before Congress right now and to illustrate where your voice could help potentially move the needle. And the best part about all of these bills is that they are all bipartisan, meaning that there's support on both sides of the political spectrum. And so I encourage you to look up these bills on your own time, learn more about them, and take a look and see if any of the bill sponsors represent your district or state. Recognizing that we only have a couple minutes left in today's session, I'm going to run through this quickly, but always happy to chat offline. I want you to really take away from this presentation is the fact that, while policy and science is incredibly important and essential, what can really help move the needle forward is engaging and legislative and policy advocacy. It's really important to remember that meaningful change does not happen in isolation and it does not happen overnight. But I think where a lot of people might face a barrier is the fact that, there are clearly abundant opportunities, but where people might get stuck is, okay, great, but how do I get involved? It can feel overwhelming, but the good news is that there are some practical and important ways for us all to contribute. First and foremost, of course, being communicating with the policymakers. Members of Congress and their staff pay attention to what they are hearing consistently from their constituents, first and foremost, but also from experts and trusted institutions. And so I would encourage you, if you want to, try meeting with your legislators and their staff, try attending town halls, share your expertise directly with them. And this is especially true for patients, researchers, and clinicians. Your voice carries weight. Explain how cardiovascular disease affects you as a patient. Explain how it's impacting the women in your clinic and how you're providing care. Explain what you're researching and the implications of that research. Your communities can really help translate the real world impact for policymakers. And then even if you're limited in capacity and can't necessarily do full-blown meetings, you can always send emails, call up the offices in your free time, or even participate in action alerts that are set up from trusted advocacy groups. Legislative offices track these contacts carefully, so please do not underestimate their impact. Another opportunity, this is a little bit more creative, but you might even want to invite your policymakers or agency reps to come visit your institution, your lab, your clinic, or your community program. Seeing the work firsthand like that can be incredibly powerful and memorable, and it's a good way to illustrate the impacts of the work that you're doing. Coalition engagement is another major driver of progress. The collaboration in coalitions can look like participating in sign-on letters, joining public comment opportunities, helping mobilize professional societies and patient networks around key legislation or regulatory actions. And finally, it is 2026. We can't underestimate the role of social media and public communication. Especially nowadays, having accurate and evidence-based communication can help raise awareness, help provide reliable information, and keep women's heart health visible in the public conversation. And then also, I just want to highlight quickly that at the regulatory level, there are also opportunities to engage with agencies like the FDA, NIH, and others directly through public comment periods, advisory meetings, listening sessions, and stakeholder engagement opportunities. And so my point is that everyone in the audience, regardless of your role or perspective, has the ability to move the needle. Sarah will cover this in the closing slides, so I won't go into detail here, but I do just want to remind you that SWHR has so many free to access heart health resources available to you, and I encourage you to check these out at swhr.org. So to wrap us up, if I can leave you all with one thing, I hope it's that we already have much of the knowledge about women's heart health. It exists, and what we need now is implementation, alignment, and urgency in our policy, and you have a role to play in that. Thank you all again for the opportunity to be a part of this conversation and for your time and attention. If you have any questions, you can reach me at madeline@swhr.org. Thank you.
Thank you so much, Madeline. I will now invite our panelists to all join us on camera. Once again, we invite attendees to submit questions with the Q&A function, and we'll try to address as many questions as we can in the remaining few minutes we have here today. And I'd just like to note that our conversation today is intended for educational purposes and is not intended or implied to substitute for medical or professional advice. We encourage all participants and patients and their supporters to confirm information and consult their healthcare providers to determine individual needs.
Sarah,
To
someone had
start,
turned my camera off, so I can't turn it on.
oh, so sorry, Claire. I can bring that back on
Thank
for
you.
you. Of course. As I do that, I would just like to open the conversation as I'm turning Claire's camera back on. I'd like to start the conversation with Dr. Graves. You mentioned you discussed disparities in access, care, and outcomes, and I'd like you to speak on how researchers can better address the heterogeneity of women in their research and get more women involved into cardiovascular trials and get more women involved into research to provide better information about the heterogeneity of women and their healthcare outcomes.
Thank you for that question. I think one of the things we have to remember is that when we talk about a population, especially in the United States, there's the heterogeneity of the population and there's the heterogeneity of the culture. So often I think we look at like the non-Hispanic Black women as one population, and that probably is one of the things we need to really consider when we're looking at populations and outcomes. The second thing is that research needs to be intentional. When I was working with one of my trials, I intentionally recruited a research nurse of color because I felt that having someone, even though I'm a person of color, I'm also a doctor, but having someone who related to that patient population would be it would allow us to recruit patients much more easily. The third thing is to be intentional in our research. Often when we're looking for flyers and things, the flyers are in communities in which the people of a certain population don't even live, or they're in a language in which they don't speak. And so we have to be much more intentional in recognizing the total heterogeneity of our population in the United States, and understanding that I always tell people what people appear to be may be very different than who they are. And so addressing language barriers and things of that nature will also allow us to involve more women, especially women who have disparate outcomes in research in this country.
Thank you so much. Next, I'm going to direct a question to Claire, but also welcome the providers to weigh in on this. Claire, in your presentation, you mentioned the importance of developing a partnership with your healthcare team. What strategies would you recommend for patients who are interested in engaging more in a partnership with their providers? And then once you respond, I would also ask the providers to share their perspectives on this as well.
I guess I can share it as a nurse and as a patient, because I think oftentimes patients come in and they're angry, And that can put up a barrier to creating a good relationship with the physician. So I think patients need to ask if they can be a collaborative effort in their care and not come in attacking and blaming physicians, because I think that happens a lot from a nursing perspective, from a healthcare provider, no, I mean, from a patient perspective, coming in with and inquiring, what are the options, engaging in collaboration with your own care and having that ability to discuss what will work for you and what won't, but understanding that the physicians really have the education and the background to help us.
Great. Next, the question I'm gonna paraphrase a question and also direct this sort of towards Madeline, which is really about how we get individuals to engage in these topics, particularly those who may not have previously expressed interest in this topic or in these topics. And I'll direct that to you sort of more on a policymaker standpoint is how do we get policymakers to be more engaged in this work and really recognize the importance of funding this research and addressing gaps in cardiovascular care.
Yeah, thank you, Sarah. When it comes to engaging with policymakers specifically, I think it's really important to remember that they have a number of competing priorities on their desk. And not only are those competing legislative and investment priorities, but also competing political priorities. And so it's really important to be aware of the environment that they're operating in. A piece of advice that I always like to give is that when you are engaging with policymakers and their staff, it's really critical to anchor your pitch in the why this issue matters now. Why is it urgent? What are the public health and economic impacts? What are the consequences if we fail to invest, for example, in women's heart health research and care? And so I think coming prepared with that strong data, and especially making it local whenever possible. Policymakers at the end of the day are accountable to and elected by their constituents. So showing how the women in their district or their state and even their families are being impacted can make the issue a lot more tangible and urgent for them. And so this means having the strong data on the health impacts, having that economic data, maybe also coming prepared with what's currently being invested, what is like the historical investment in women's heart health and what's needed to be making improvements, and come prepared with specific strategies and policy recommendations in mind. They kind of have the question oftentimes of like, okay, so what do you want from me? So come prepared to answer that question. And then also, whenever possible, I find that it can be really valuable to pair that data with real stories. And so I spoke to this a little bit in my presentation, but the statistics get the attention and that's necessary, but the personal stories can help sort of illustrate that emotional connection and can help drive the action on behalf of the policymakers. Chances are the policymaker that you're engaging either knows somebody or they themselves have a heart health story to tell. And so making that personal connection, I think, can have a greater impact than we often recognize.
Thanks so much, Madeline. So we have flown through the Q&A portion. So I am just going to ask that before we wrap, I'm going to ask one final question for all of you, which is just if you could have a suggestion for one solution, whether it be small or a long-term strategy to address research, healthcare, or policy gaps in women's cardiovascular health, what would that be? And I'll start with you, Dr. Lau.
Well, thank you so much. I think that's such an important question as we think through all of the gaps that remain. One of the things as we think specifically about life stages for women is that our studies, our patient-oriented studies, observational studies, randomized trials really don't capture reproductive risk factors, female-specific risk factors in a robust way. And I think that's because they're complicated. The data are challenging, but I do think that the onus is on us to sort of demand not only that we include equal numbers of men and women, but that actually we're very thoughtful about additional risk factors that we want to ascertain about women as they are relevant to cardiovascular health.
Great. And then Claire, would you mind for sharing as well?
I think it's really important that we present to patients in a way that they understand that they're not only helping themselves, but they're helping the future. For me, it was that when I was a research coordinator, that was the way I would present to patients to help them understand. A lot of times they feel that they're guinea pigs, and I had to shift that in them. I think I feel valuable because I have a stent that someone else allowed themselves to have research on. And so I share that perspective. So teaching women that it's really important to help advance our healthcare, particularly for women, because we are different than men.
Dr. Graves.
I think one of the things also is for us to tear down some of the silos that we work in. Often what happens is that women's healthcare always talk about how people see pregnancy, the reproductive years as the event. You know, you have children and that's your event. We need to really tear down silos and look at women's healthcare as a continuum from the time that they are adolescents who are going to be childbearing, who have the potential to be childbearing, all the way through the entire life cycle. And when we do research, we need to look at it from that perspective instead of the siloed way we have been doing it in the past.
And Madeline.
Thanks, Sarah. In addition to the solutions that were proposed by the other speakers today, I would like to take a little bit of a zoom out and provide something a little bit more abstract, and that would be a sort of sociocultural and systemic change through the fact that, women understand our health the best. So we need to be believing women when they come to their providers and say that they're experiencing these issues and symptoms. And we need to be empowering patients to be able to speak up to their healthcare providers and to know what questions to ask, to know what services they might have a right to, and to understand how to navigate the healthcare system at large.
Wonderful. Well, thank you all. Thank you to our panelists for your time and insights. And SWHR thanks VCU for support of this Emerging Topics in Women's Health Symposium and the Heart Disease Research Foundation for the support of our work. SWHR will continue this conversation online with SWHR Talks Heart and across our work to improve women's heart health across the lifespan. Visit our website to access free heart health resources, including policy agendas, fact sheets, toolkits, and webinars. And you can connect with us on our website, as well as on social media to download women's health resources, register for future events, and sign up for our newsletter. We will be sending out an email with a recording of today's symposium to all registrants, as well as post the recording on the event webpage for future viewing. So be on the lookout for that and feel free to share with others as we continue this conversation with SWHR Talks Heart. Thank you all for joining us today.